Good morning. My name is Barbara Velasquez, and it is my pleasure as Coordinator of International Intercultural Education to welcome you to the final presentation in this academic year for Metropolitan Community College's 16th Annual Diversity Matters Lecture Series. Your microphones and chat with other audience members are turned off. Please send your messages or questions for the speaker through the chat to moderator Barbara Velasquez. Also, please watch the chat for a link to an online evaluation. Dr. Athena Ramos is an assistant professor in the Department of Health Promotion and is affiliated with the Center for Reducing Health Disparities and the Central State Center for Agricultural Safety and Health at the University of Nebraska Medical Center in Omaha, Nebraska. She leads a Latino outreach and engagement team and serves as principal investigator for a number of community-based health and social research and education initiatives in such areas as occupational health and safety within the agri-food system, immigrant integration, and community well-being. She has 20 years of experience in health promotion, strategic thinking, community development, and public relations. Ramos has a PhD in International Family and Community Studies from Clemson University and 2 master's degrees, one in Business Administration and one in Urban Studies from the University of Nebraska at Omaha. Dr. Ramos is a member of the Agricultural Safety and Health Council of America, AgriSafe Network, National Alliance for Hispanic Health, Global Alliance for Behavioral Health and Social Justice, the National Hispanic Network to Reduce Tobacco-Related and Cancer Health Disparities, and Welcoming America. She also serves on the board of directors for the International Society for Agricultural Safety and Health, the Omaha Community Foundation, Spark Community Development, and Comunidad Maya. And I'm sorry, I didn't check the pronunciation, Pixan Ixen. I probably have that wrong. I am confident that you will immediately notice that Dr. Ramos continuously strives to bring a sense of hope and vitality to the work that she does, both professionally and personally. She has been honored numerous times for her commitment and dedication to making Omaha and Nebraska a healthier, more inclusive, and vibrant place to live, work, and play. She was recognized as one of the 40 under 40 by the Midlands Business Journal, one of the 10 outstanding young Omahans, the American Heart Association's Advocacy Volunteer of the Year, the Nebraska Latino American Commission's Inspiration Award recipient, and a WCA Tribute to Women honoree. Recently, she was awarded the Kareth J. Wagner Faculty Prize in Public Health from UNMC College of Public Health for her work during the pandemic. Dr. Ramos is married and is the mother of 4 children. Please welcome Dr. Athena K. Ramos.
Well, thank you so much, Barbara, for that introduction. Good morning, everybody. It's such a pleasure to be with you all today. If you give me one moment, I'm going to pull up my slides. Perfect. I believe you are seeing the full slide version here. I got some head nods. Okay, perfect. Well, good morning again. This morning, I plan to talk about some of the challenges that essential workers experienced during the COVID-19 pandemic. And so I'm going to focus my presentation on the work that we've been doing with meatpacking and with meatpacking workers and the meatpacking industry over the past 2 years. And so I will talk about some of the dirty, dangerous, and demanding work that is experienced in the meatpacking industry. I'll talk to you about some of the data and the statistics associated with the COVID-19 pandemic in that sector. And then I plan to highlight some of the workers' narratives and the stories that they shared with us about what it's been like to be an quote unquote essential worker during the pandemic, and share some of their ideas for improving health, well-being, and safety moving forward. So first, let me start by giving you a little bit of background on this industry. I bet all of the folks in the room today have some sort of connection to the meatpacking industry, being that we're here in Omaha and we're surrounded by meatpacking companies, and we have a long history, especially in South Omaha, of being home to the Livestock Exchange Building, which is right near our South Campus, and to all of the sales that went on there, which ultimately ended up in mostly in the packing industry that surrounds the South Omaha campus. Either that, or you know somebody who works in the industry, or you yourself have had a family who have either been a worker in some of those facilities, or maybe perhaps you yourself have had that experience. But to start out, let me give you some background. So here in the United States, there's about 500,000 people who work in what they call the animal slaughtering and processing industry. And over half of all of the meatpacking plants in the United States are located right here in the Midwest. So this is a huge industry for our state and also for our region. If we look just at Nebraska, there's approximately 28,000 people who are employed in meatpacking facilities throughout our state. We consider meatpacking to be a 3D job, or a 3D industry. 3D meaning dirty, demanding, and dangerous. And I'll talk to you a little bit more about that as we go forward. But it's also an industry that employs a lot of people who are immigrants, who are racial and ethnic minorities, refugees, asylum seekers, and perhaps people who have some involvement with the justice system. The meatpacking industry has a long history, and maybe you've even heard about some of the cases, but a long history and a pretty poor track record on safety culture and on employee health and well-being. And this is even before COVID hit. So OSHA, which is the Occupational Safety and Health Administration, had actually set up a special emphasis program to try to explore why there's so many injuries in the meatpacking industry and try to bring that number down. And the meatpacking industry has been the subject of lots and lots of reports by human and labor rights advocates. I mean, if you do any type of research on this industry, you will find a number of reports from Human Rights Watch to Amnesty International to even Nebraska Appleseed, who have been doing a lot of research on this industry and trying to promote better safety practices throughout the industry, again, even before COVID hit. So we have also been doing research in this industry even before COVID hit. And some of the things that we found in our previous studies were that in talking to workers, they felt like there was very little that they could do to prevent and treat any health problems that they had. They felt like injury was something that was inherent in the work, and that injuries like repetitive motion types of injuries, slips, trips, and falls, getting, an accidental stab, or maybe getting some part of your body crushed by different types of machinery, those were all expected injuries. They were expected as part of the job that they were doing. So they found it very normal. The idea of getting injured in this industry is very normalized. There's also a point system. And for those of you who have had some experience with this industry, it's a disciplinary point system. So the way that I like to think about it is think back to kindergarten or to elementary school. And we had the little sticker charts with the stars, and you get stars for getting good behavior. This is sort of the opposite. You get points for having bad behavior, sort of like a demerit system. And after a certain number of points, you're ultimately terminated. And so this point system is also related to health, because oftentimes people don't want to take the time it requires to heal or to get sick because they're worried about getting a point and ultimately losing their job. They talk to us a lot about the line speed and how fast the work moved throughout the day. And so that, again, it didn't leave them with a lot of opportunity to actually take care of themselves. And so they had to rely on reactive types of strategies in dealing with pain at home or after working hours. We also found that the workplace had very few cues to action to motivate or incentivize self-care at work. And so what does this mean? Well, it means that there isn't, you're not going to have like the health promotion posters, on the wall. Hey, eat your 5 food groups, look at your My Plate, or any of these types of things. It means that they really focus on the acute injury. And so, for example, like getting cut and that sort of thing. And they tell you at a safety meeting that perhaps right when you got hired, the safety meeting or the safety training, that it was dangerous work. And so how workers interpreted that was that they already told you that the work was dangerous. So if you end up getting hurt, it's basically your fault because you didn't follow the proper protocol for avoiding that type of injury. And the third thing that we found is that workers had very little confidence and trust in the occupational health office, and they didn't see a lot of benefits from accessing services there. So for example, if they did get a cut, they would go to the nurse's office, they might get a Band-Aid, put the Band-Aid on, maybe clean off the wound, and back to work you go. Maybe you had a back injury and had some pain that you were experiencing from standing and doing the same motions all day long. You might go to the nurse's office and you get an ice pack and you sit for 20 minutes and then you go back to work. And so they didn't see that there was a lot of care, you could say. They felt like they weren't really being cared for, that they got poor treatment when they did access services there, and that the services that they had were limited. Basically, they were for an acute injury. There was nothing more long-term thinking about how do you maintain health and well-being in the workplace, but really dealing with, something serious that happened on the job. And of course, there were communication challenges. So as I mentioned, the meatpacking workforce is very diverse. And there's a lot of communication challenges in the health office because many of the people who staff the health office are English speakers only, or perhaps maybe they have some Spanish language skills. But when you're looking at some of these facilities as workplaces, they're really, really tremendously diverse, which is pretty incredible. I've traveled to a lot of meatpacking facilities all throughout the Midwest, and although we're here in Omaha, we have a really kind of cosmopolitan type of atmosphere. Many of these facilities are located in very rural communities. And so this is like the hub of diversity. And so you might have 25 to 30 different languages that are being spoken in the facility. And so dealing with that and how to communicate with people is definitely a challenge for this industry. So then comes the COVID-19 pandemic. And meat processing workers were then considered essential workers. And so the government mandated that essential industries basically remain operational so that we can ensure an adequate food supply for the country, right? And we saw very early on during the pandemic that there were a lot of facilities that experienced these huge outbreaks, hundreds of cases at a time. And so both workers and employers were really scared. They were really nervous about what this was going to do to their work and to their workforce. And they were looking for solutions. And here in Nebraska, the governor called on UNMC to help the meatpacking sector try to remain operational and try to put into place some protective strategies to try to mitigate or reduce that risk of COVID-19 transmission in the workplace. So from UNMC, we actually had a team of scientists actually go out and do site visits to meatpacking facilities all across the state. And through those site visits, we provided technical assistance and gave them recommendations on what might be best practices that they could implement in their facility. And we actually drafted a playbook, which you can see on the bottom left-hand corner of the slide, with these recommendations and best practices. This book actually came out before there was any federal guidance from OSHA or from the Centers for Disease Control, or anybody had put out anything for the meatpacking industry. So this is early April of 2020 that we put out this playbook to try to help the industry. Now, as part of those site visits, our team realized that maybe we weren't getting the whole story. For those of you who may have experience with the meatpacking industry, you know that when you go in and when they know that they're having visitors, just like if we know we're going to have visitors to our home, we clean up, right? And you don't want to show anything. You don't want to show your dirty laundry, right? When you have visitors to your house. The same is true for site visits in an industrial place. And so workers were telling us that, maybe you're not hearing the whole story, you're not seeing the whole story. And I'll tell you what we did for that here in a minute. This is a heat map of the impact of COVID-19 on the agri-food system. So if you look at all the red dots, those represent outbreaks in meatpacking facilities across the United States. So you can see there's a huge concentration of these red dots in the center part of the US, basically the Midwestern region where we're at, because we do have so many facilities here. But you'll also note that there were a number of food processing facilities and farms that also had large outbreaks. So on the bottom, you'll note that there was nearly 1,500 facilities and over 400 farms that reported COVID-19 cases, and over 90,000 workers who tested positive, and 466 workers who died from COVID-19. Now, let me put a caveat out there. This data comes from the Food and Environmental Reporting Network. And so they tried to get data from all of the state health departments, which was unsuccessful. And there really is no national source of data on these types of outbreaks. Many states limited access to information throughout the pandemic. And so what you're seeing on the map is a very limited picture based on some data, but not full data. But even then, you can see that this had a huge impact. There was a congressional report that came out recently that during the first year of the pandemic, there were over 60,000 meatpacking workers who had tested positive for COVID. Now, that's a lot of people just in the first year, and that is an increase from what they had said previously. So again, we're dealing with underreporting and limited reporting on the state level. But even so, these meatpacking facilities have been considered vectors of community transmission. And it's estimated that these plants were the source of nearly 350,000 COVID-19 cases in the US during the first year. And if we wanted to look at the economic impact that stemmed from those cases, we're looking at about $11.2 billion in just the first year of the pandemic. So again, a tremendous impact both on the human toll of the virus, as well as on the economic consequences that resulted from that. Okay, so I told you that we maybe didn't get all the story when we visited these facilities. And so our partners encouraged us to try to document workers' stories and try to understand what it is like from the worker perspective. If you remember the media that was coming out, there was lots of news articles that were talking about how, all of these major companies, the big four companies were providing everybody with paid leave, and they were closing facilities, and they were giving everybody lots of benefits, and they were, doing everything that they were supposed to do, basically. The workers we talked to and the community advocates that we talked to said, maybe not. And so we took their advice and we conducted a study actually during May of 2020. And this study, as you can see, was open. It was an online survey that was open between May 7th and May 25th. So a very short time frame. I was expecting maybe we would get 200 responses on this survey, maybe. That would be really good. But much to my surprise, we had over 1,000 responses on this survey, and we had 637 of those responses that were full responses that we've used for our reporting purposes. And so with this survey, we tried to understand how the work environment had responded to the COVID-19 threat. And then we asked them about information and material barriers that they may have experienced, and the types of preventive strategies that have been used outside of the work environment as well. As you might recall, some of the media talked about how the workers had gone to a quinceañera, or they'd gone to a wedding, or they'd gone to a big party, and that's how come everybody got sick, and it had nothing to do with the workplace. And so we were trying to combat some of those stereotypes, through this study that we put together. So the survey was, as I mentioned, was available online. We had it available in English and Spanish and French, and we promoted it heavily through the Spanish language media. And this was an IRB approved study. So here you can see the employer responses to COVID. Now, I think this is really interesting, and this is something really important and that we've used a lot with our work moving forward since May of 2020. So on the on the left-hand side of the slide, you will see the things that are that were most frequently reported by the workers. So for example, workers talked to us about how they had temperature checks when they were coming into the facility. They talked about how the facilities made everybody wear a mask. They talked about some of the multilingual signage that may have been posted throughout the facility, right? Those are things that our team saw as well. But some of the things that we knew at the time would have made the most difference, like for example, making sure people had paid time off, or even though the company said they had paid time off, you can see here that roughly about 30% of workers reported that they had access to paid time off. So 70% of the people who responded said they did not have access to additional paid time off because of COVID. Things like reducing the density of people in the facility. Again, 80% of people said that didn't happen in our workplace, even though those were some of the things that were promoted in the media. And so this type of information helped us to drive some of the outreach and education efforts that we had with workers during the pandemic. Now I'm going to show you some comments because this really surprised me. We had put some open-ended questions onto the survey, and thinking maybe somebody might put something. Little, did I realize that people were needing an opportunity, needing an outlet to talk and to share their stories. And so we had hundreds of comments that came in the survey, and we felt like it was our responsibility to also be able to share some of these stories that workers had shared with us. And so we went through a qualitative analysis of all of the comments that we received, and we categorized those into themes. And so here you can see the first theme is that workers really describe the plants to be places that prioritize production over people. This is consistent with our findings even prior to COVID, that production is definitely more important than the people doing it. And you can see some of the things that they mentioned. That they don't care about their workers, they only care about money. Each person's life for them is just another cow. Aren't we essential workers? They should take better care of us and respect our lives more than money. I mean, these are really heavy hitting types of comments that make you say, wow. A second theme that we saw was that COVID really sparked fear and distress among workers. And for example, here's two people. One mentioned, well, more than an experience, it's a worry because I can't stop working and I'm very afraid for the well-being of my family. Another person noted that there's some coworkers, some people that have died, and that's what has affected me the most. Imagine standing on the line and your coworker doesn't come in that day. Nobody was telling you why your coworker didn't come in that day, but everybody assumes they didn't come in because they had COVID. But what if they don't return? What if those 2 weeks pass and they never return? This hit workers really hard to know that they were in a place like potentially that could have been them. The third theme that we saw was that workers really felt like their employers started to take action too late, if they had taken any action at all. And that those financial incentives that some of the companies had put into place had actually put people at more risk because they motivated sick people to come to work. So for example, One person noted, "I'm scared to go to work without knowing the exact number of cases there are. That $30 daily bonus was useful in getting sick people to return to work, and that puts us all in more danger." And many of these companies use these financial incentives to try to maintain the workforce that they needed to ensure their production, right? You have production goals, so you have to have people in positions. And when people don't show up, that means production goes down. And so they used daily bonuses, or some companies called it a responsibility bonus. If you showed up for all of your scheduled shifts during the month, maybe it was a $500 bonus or something like that for that month period. But, thinking about the wages in this industry, which at the time were very low. I mean, an average wage at that time was about $16 an hour. And would $16 an hour motivate you to come to work if you were going to be exposed to COVID? Maybe, maybe not. But would an additional $500 a month make a difference? Probably. Right. And so that's how those companies justified some of those actions. The fourth and final theme that we saw from the workers' comments were that they talked about being structurally vulnerable, and they felt like they weren't heard, they weren't seen, they weren't valued, and they definitely weren't cared for by their employers. For example, others are fearful due to their immigration status, and the majority are scared that they won't be able to pay their bills or that they lose their job. The people in the plan who don't know how to read or write, older people, and that makes it difficult to apply for help because they don't know how to write, much less speak English. The common denominator is that they are scared to be without a job and pay their bills, so they go to work sick. Another person noted, "We need to work, but we also need them," talking about the employers, "we need them to take care of us." So those were some of the highlights from this very first study that we conducted during the COVID-19 pandemic. This promoted us or motivated us to try to do something for workers because they weren't getting a lot of information. There was a lot of fear. They didn't know what to do. And so we created some educational materials on our end about simple things that you can do at work or at home outside of work to try to protect yourself from the virus. We created these, they were printed materials originally in English, Spanish, Arabic, French, Vietnamese, and Kanghobal Maya, which is a Mayan indigenous language. So as I mentioned, they were printed materials, but they also went out via social media and boosted Facebook posts. We sent them to all of our partners who were working with us. Many community organizations also disseminated these, such as the South Omaha Neighborhood Alliance, Nebraska Appleseed, the Migrant Education Program, Proteus. A lot of different organizations were using these. We also promoted all of this type of information on Spanish language media like radio, TV. I had my team doing interviews all over the place via Zoom during this time to try to share the information that we had, because basically we were in a very privileged position because we had information that could potentially protect people's lives. And we felt so committed to sharing this information that we did everything we could to disseminate it. With the Kanghobal language, that was a very interesting experience because Kanghobal is mainly a spoken language and not a written language. So we did not create any printed materials for Kanghobal, but our community partner, which Barbara mentioned in my introduction, the Comunidad Maya Pishan Ishim, they actually took the printed materials we had and they spoke the information over people playing marimba, because they said, well, everybody in our community listens to marimba music. And so the way that you need to get to them is put it on put marimba behind it. We'll speak over it. We'll put it on YouTube. And that's exactly what we did. A very interesting way to outreach to a community. So throughout the pandemic, we've learned a lot of lessons about how to do outreach and what are some of the strategies that work in different communities. So that first study led us to so much more. We were able to secure a large grant through private funding to conduct an exposure assessment of the SARS-CoV-2 virus in meatpacking facilities. We're one of the only teams throughout the country that has this type of access to meatpacking facilities. As I mentioned, they're not too hip on having a lot of visitors usually, but we were able to work through the national union, which is the United Food and Commercial Workers, as well as through many of our industry contacts to be able to get this study funded and conduct the study. So with this study, we actually did on-site measurements in 3 different meatpacking facilities. So those on-site measurements included collecting air samples from throughout the facilities to try to explore the potential for aerosol transmission. So if you think back to early in the pandemic, there was a big scientific debate on, is COVID transmitted through droplets or through aerosols? And so we were trying to help answer that question in meatpacking facilities. As you might have noted from the slide with the employer responses to COVID, you saw that a lot of people reported having plastic dividers being installed on the line. And so this kind of came as a question from the union. Do those work? And so we figured we need to explore that route of aerosol transmission in the facilities. The second part of the exposure assessment was to look at heating, ventilation, and air conditioning systems, or HVAC systems, throughout the facility and look at airflow patterns. Third, we thought it would be important to talk with the occupational health office and the nurses or doctors that staff those offices. And then again, document workers' narratives from the facilities that we visited. So we got the meatpacking companies are very interested in number 1 and number 2. They did not really like the idea of us talking to anybody. That was a little bit tricky. In fact, they did not allow that in their facility. And so my team actually had to conduct interviews with nurses and with workers outside of the work environment. And we couldn't even mention that we were doing this study when we were in the facilities. So they were very focused on making sure we do 1 and 2, and then don't open your mouth to anybody is basically the message that we got. So this study, as I mentioned, we went into 3 different facilities. You can see the timing of the 3 different facilities that we visited, site A, B, and C. A occurred in March of 2021, C occurred in August of 2021, and site B occurred in September of 2021. We went to 2 beef packing facilities and 1 poultry processing facilities. You can see most of those facilities had a pretty large workforce. The beef facilities in particular had large workforces of about 3,500 apiece. And in the poultry facility, it was roughly around 1,000 to 1,200 people, depending on the time. So for the on-site sampling, we collected air samples in 3 different areas. 1 being the kill areas, or what they call the harvest areas. So when the live animal comes into the facility and they're basically taking everything out, that would be considered a kill area. The fabrication area is once that the carcass has been chilled, they actually take the carcass and cut it into different cuts of meat. So a ribeye or hamburger or whatever the case may be. So those are the 2, meatpacking facilities are divided into basically those 2 areas, kill and fabrication. And then the third area that we explored were the common areas. So thinking about places where workers may be outside of production areas. For example, entryways, locker rooms, cafeterias, bathrooms, and so forth. So air samples happened in all 3 of those places. And we also installed monitors for CO2, carbon dioxide, into air handling units on the rooftop, especially for air handling units that served common areas throughout the facilities. We also looked at diffusers and those airflow patterns within the space in those common areas. With the air samples, sorry, let me go back. The air samples, we actually did 2 different types of air samples. So the first one would be long-term sampling, where we installed a monitor that we would leave over the course of several days. And the other would be a discrete sampling, which happened where we would actually go to all of these spaces and put our teams into a pattern across the space and stand in the space with our monitors for about 40 to 45 minutes at a time. And so we would make these patterns throughout the kill areas, throughout the fabrication areas, and throughout the common spaces. So now I'm going to share with you some of the results of that first component of the exposure assessment. So here you can see we did find some COVID positive spaces using some surface swabs in a fabrication area near a boot wash facility. So like there's a wash area so you can rinse your boots off so you're not tracking whatever you had in the production area into other parts of the plant. We did find there was a positive sample there, and we also had a positive sample from a men's locker room near an exhaust vent. For our preliminary long-term samples, we did get one sample that was positive near an equipment checkout point in a main hallway. Here you can see in Site A, when we actually came on site to do our sampling campaign, which is a 3-day campaign in each facility, we did not find any COVID, but you've got to think back to the timing of the study. This was towards the end of March, later March of 2021. Vaccines had already started rolling out. Workers were already vaccinated. There had already been on-site clinics at the work facility. So we weren't expecting to see a lot of COVID at that point, truthfully. And that's why we also measured for a respiratory surfactant protein. So this is a protein that is expressed as people breathe. This is a marker of, and could be a marker for any type of respiratory transmission of disease. And you can see there's lots of positives of respiratory surfactant protein, from fabrication areas to also some of the more common areas. So those were, that gives us, I think, some new things to think about, and how do we protect people beyond COVID for any type of respiratory disease that may be transmitting, including seasonal influenza. Site B was relatively the same story. We didn't find any COVID, but we did see some positives for the respiratory surfactant protein. And Site C, again, very similar story, mainly respiratory surfactant protein. In fact, we saw 34% of the samples that we took in this particular facility were positive from common areas for that respiratory surfactant protein, and 18% of the samples from production areas, so thinking about kill and the fabrication areas, came back positive for that protein. We did find that there was one sample from a men's locker room that did come back positive for the SARS-CoV-2 virus. So this actually supplements much of what we saw with the HVAC assessment. And with that, as I mentioned, we had installed a number of monitors for carbon dioxide into the air handling units on the rooftop. Never in my wildest dreams would I have imagined scaling a ladder at a meatpacking facility and climbing on a roof. That wasn't part of my game plan, but now I can check that little box off my bucket list. This exposure assessment was a really unique project because it was so interdisciplinary in nature. I'm a public health practitioner, a public health type of person. Usually I do studies with community organizations, and we work together well because we're all in it to try to keep people safe. And this project, I got to work with the aerosol scientists, which you've seen some of their results now. I got to work with HVAC engineers, and I got to work with occupational health nurses, and then of course bring together my social science team. Going back to the roof now. So we're on the roof and installing these rooftop carbon dioxide monitors, and we did find that there were many of these facilities that had very poor ventilation, that common areas especially were under ventilated. So if you think about cafeteria or a locker room, or a bathroom, when people are most likely to take off their mask and interact with people in a very close manner, these are the places that have the worst ventilation. They have the worst airflow and very unbalanced airflow. So if you were to look at a room, let's say you've got a rectangle shaped room and you've got 12 diffusers around the room, one of those diffusers, maybe two, may have good airflow coming out of it, but there may be 2 or 3 or 5 or 6 that have no airflow at all. And so the only air that may have been entering into these common spaces may be through leakage, if you're opening a door from the outside into the facility, or there was something else happening, like maybe it was a door to a roof and somebody had to go check on something on the roof. That might be the only way that you're getting airflow into that part of the facility. Now, part of the reason why these facilities don't have outside air coming in is because they're trying to reduce contamination of meat. I think we can all agree we don't want to eat contaminated meat or meat with bacteria or other funky things that are growing. I'm with you. And that's exactly what we found, is that many of the production areas have very good ventilation, but it's for food safety reasons, not for worker comfort or for worker health and safety reasons. It's for food safety reasons. But those common areas don't have that same expectation. And so there is, like I said, very little airflow and a very unbalanced airflow, if there is any. Which is a problem with COVID, because we know that COVID is transmitted through the air, right? And so if you're taking off your mask, that was your one protection before there was a vaccine, there was a high likelihood that there was transmission happening in those common spaces. This is exactly what workers were telling us. You need to look at the bathrooms. It's so crowded. You need to look at the cafeteria. Everybody's like, taking off their mask. And even though they put those plastic dividers on the table, they don't work. That's what the workers would say. And truthfully, they're right. They were right. We also found that in the air handling units, there were low quality filters, air filters. For any folks that I've learned a lot about engineering lately. So for any folks that know about ventilation, there's a rating of filters, and the higher the rating, the better the filter. And so some of these facilities were using what's called a MERV 8, when the recommendation from the heating ventilation professional organization is a MERV 13. So they're far behind. And there were some units that weren't working at all. In fact, we went into one facility and we were trying to measure the airflow in the women's locker room. And we went in, me and a colleague, a female colleague of mine, we went into the locker room with our equipment. We're doing the measurements. We couldn't get any air measurement at all from any of the diffusers in there. And so when we came back, our chaperone from the facility said, "How'd it go?" We said, "Well, we couldn't really find anything." He said, "Really?" Said, "Really? We couldn't find anything. There was no airflow whatsoever." He's like, "I wonder if they have the system turned on." The system had been off. So he called somebody from their from their maintenance team, and they went and turned on the system. But how long had that system been off? Who knows? Who knows? It might have been off the whole pandemic. Nobody really knows, but it took us asking about that to get a change. A worker isn't gonna, you and I, we're not going to go in and say, "Well, there's no airflow in here. I wonder if they have a system on." It doesn't cross like our minds. You kind of expect that the building is going to be in working order whenever you come into your workplace. But what we found is maybe that's not always the case. I mentioned that we also did some surveys with workers, and we've done a number of interviews with workers. And here you can see some of the demographic characteristics of the people that we talked to. So I'm gonna share just a little bit of the survey results. I'm gonna focus a lot on the interviews that we had with workers. I think those are very interesting, but you'll note from the demographic characteristics here that 85% of the people that participated in the survey are foreign-born individuals. About 70% of the people that we interviewed were foreign-born individuals. You can see where they worked in the plant. A lot of people were working on the fabrication side, and there was some from the kill side. Typically, the fabrication side has more people employed because it takes more people to do that kind of work than it does on the kill side or the harvest side of the facility. So we talked to people with really diverse backgrounds, different languages, different ethnicities, different countries of origin. I mentioned refugees, asylum seekers, immigrants, and lots of other quote unquote vulnerable individuals, including people who were military veterans and people who had been involved in the justice system. We did interviews in English and Spanish. Survey was available in English and Spanish, although we were limited to those two languages. So from the survey, we asked people to talk to us about some of the early responses to try to see how the workplace had responded, trying to verify the results that we had gotten from May 2020. And again, we saw very much of the same story. There was temperature checks being done at the facilities. There was a universal mask policy, and usually there was some sort of COVID testing protocol. The least reported responses to COVID were transparency in the cases. There was nobody telling you, hey, if the person next to you doesn't show up, they had COVID, maybe you should get checked. That didn't happen. And they talked about that there wasn't any distancing on the line. And they talked about very few people reported having any types of improvements in ventilation. I wasn't expecting a lot of people to report any changes in ventilation because a lot of people just don't know about that. So I'm not surprised at all by that. We also asked them to talk to us about what is your workplace doing now. So these surveys were actually conducted between June of 2021 and December of 2021. And you can see here that the most reported types of responses were having a vaccine clinic on site, or bringing in the health department or somebody to give vaccines on site, making new masks available throughout the day. That was a real common complaint early on, was that workers didn't have access to more than one mask per day. So if you can imagine working in one of these facilities, you have your mask on and you're working with blood and guts and chemicals and water and all kinds of stuff, your mask gets dirty, nasty, wet, and you didn't have any opportunity to get a new mask. But now they were reporting that new masks are available, and so they can take as many as they need throughout the day. They also talked that there was additional sanitation facilities that had been installed in the facilities and that they provided free COVID testing. The least reported items, again, are transparency, slowing down the line, having paid time off for a COVID exposure, and bonus pay or hazard pay that may have been associated early on with trying to maintain the adequate workforce that was needed in the facilities. We asked them about their health-related attitudes and their perceptions. And here you can see that most of the workers reported pretty good, very good, or excellent health. They had a decent amount of trust in public health authorities, and most had been vaccinated already for against COVID-19, but they felt pretty likely that they were going to contract COVID regardless in the next 3 months at work. The reasons why people did get vaccinated was, number one, to protect their family and their friends, even more so than it was to protect themselves. Third, to protect coworkers, and fourth, to stop the pandemic. So I think these gives us some guidelines for how we need to message about COVID vaccines, right? We need to talk to people about the importance of doing it to protect their family and their friends instead of focusing on, just on your coworkers or yourself. So we've got to think more around the collective. Some of the reasons that they gave us for not getting vaccinated were because they didn't trust the vaccine. If you remember, during that time, there was a lot of misinformation about the vaccine and the potential side effects from the vaccine, both acute side effects and long-term side effects from getting vaccinated. Now, let me dive into some of the worker interviews. So we conducted over 50, but this analysis is actually from 50 interviews that we conducted with workers. As I mentioned, we had to find people after working hours in the community and talk to them. And this is a really daunting task to try to do this type of work, especially with meatpacking workers who live in so much fear, oftentimes because of the undocumented status and the worry about maintaining their job. But we really found 5 key themes, which are listed here, and I'm going to dive into each theme in more detail. But the information highlights the human dimensions of essential work and the experience of working in an industry with a high risk of infection, and that one that had a lot of outbreaks all across the country. And so by listening to workers, we're able to deepen our understanding of the challenges that many of these workers face, not only at work, but what COVID has done outside of the workplace in their lives. And these findings and these themes actually corroborate the results and the recommendations that we've produced in other areas of our exposure assessment, and may help us to better guide the responses of employers and local communities. So let me go to theme 1. All right, so theme 1, workers have demanding jobs and precarious lives. Yes, they do. So they talked about reasons why the work was so demanding, because it's so fast paced. They're working in extreme temperatures. So on the fabrication side, it's cold. And I can tell you from firsthand experience of taking air samples and standing in there, we would rotate about every 45 minutes throughout the fabrication side. But we spent probably about 4 hours a day in there, and it was like being in a freezer. You basically put the humans in the freezer and they cut the meat in the freezer so that no bacteria, nothing grows on the meat, but it's very, very cold. On the other hand, if you're working on the kill or the harvest side, it could be really hot because you're exposed to outdoor air and live animals that are coming into the facility. So you have these temperature extremes. They talked about the repetitive motions and the pain that they experience pretty much on a daily basis from doing this kind of work, and the chemicals that they're exposed to. You'll note that there's a couple of quotes that I've given here that are samples of this. One person said, "You're going to do the same motion for 8 hours, 5-6 days a week. You get 1 day off a week, 1 day, so you don't heal. You just like become accustomed to it, and eventually the pain goes away. But sometimes I still hurt. When I first get there for the first hour or two, my hands go numb. I can't feel my knife sometimes. I drop it." They talked about the precarious nature of their lives as well. So as I mentioned, many of the people who are working in the industry are immigrants, refugees, asylum seekers, people who have been involved in the justice system or military veterans. And that puts them in a precarious position, right? So the workers that we encountered in this study are basically characterized by this shared experience of precarity. And precarity in this sense, it really refers to that vulnerability that people experience due to socioeconomic or historical circumstances beyond just the shared precariness of the human existence. So in other words, the people most at risk from COVID-19 in the meat processing industry, the meatpacking industry, are the people who are already particularly vulnerable. And so they talked about how the companies basically capitalize off this vulnerability and off this precarity. For example, one of the people that we talked with told us about how he would be homeless if he lost his job at the company because he lived in a company-owned apartment. So in this tiny little rural town, there was no housing available. And so the company struggled to recruit people to work because they didn't have any place to live. So the solution was build company housing. But now, if you lose your job and you're living in this tiny town, you have nowhere to turn because you will lose your home as well as your job. So people really feared, again, that point system, because the points will actually lead to termination, not only losing the job, but being homeless. Theme number 2 is that COVID impacted the well-being of workers in the workplace, right? And so 5 sub-themes emerged from this. First, workers really described experiencing and witnessing illness at work. And again, it was characterized by uncertainty about the virus and how it spread and what are the risks for exposure, what's happening with my coworkers and what's the company's response. And workers felt like there was so very limited transparency from the company, which really increased that level of uncertainty and fear that they experienced. A common perception was that the company was too slow to respond, and they prioritized production again over the health and safety of the people working in the facilities. They talked about becoming ill at work, their concern for infecting others, as well as the traumatic experience of the stress of witnessing sick and dying coworkers in their facilities. So people would, quote unquote, vanish, just never knew what happened to them. And so the rumors would circulate, and it was really very stressful for a lot of workers. Second, they talked about being really feeling like being compelled to work by their employers and pressured by their supervisors to remain on the job despite being sick or having any type of risk of exposure. We heard about that system of incentives, again, that encourage people to come to work and their supervisors to get them. So the workers may have gotten, a line worker may have gotten that responsibility bonus, but there's a very perverse incentive system for supervisors where they may have been making, instead of $500 a month, maybe $500 a week for making sure your people are there. So it really put a lot of pressure down from the supervisor level to make sure that they had an adequate number of team members available. Third, the experience of workers was really shaped by these interactions with supervisors. Like I said, they wielded a lot of power. And so the workers talked about these problematic and unequal power relations between the workers and the supervisors, along with lots of perceptions that they were unfair, that they were harsh, and that they were inconsistent in how they doled out points, right? And so there was a lot of favoritism and sexual harassment, and again, that pressure to work. Fourth, workers talked about how COVID-19 basically made everything on their job worse, right? It impacted their bodies and their well-beings, and they talked about the fatigue and the pain and the stress that's associated with the fast-paced and repetitive work on a normal basis. But imagine still having to maintain the same production with half the people. So it really did put a lot more pressure on them. And finally, fifth, they talked about a variety of measures that plants had taken to try to reduce exposure, as I've shown you in the slides, like those temperature checks and the masking policies and the plastic dividers and additional cleaning crews. But they also talked about how they felt everything was so slow, it was really delayed, and they really didn't take into account the workers' health and safety along the way. Some noted that there was some important steps that had been taken, but there was also a common sentiment that some of these measures aren't really addressing the risks that are associated with how work is organized in the facilities, like the close working conditions of people on the line and the crowded spaces throughout the common areas of the facilities. And so these like costs and benefits of the different measures were contested, and they were perceived differently among the workers. Let me give you an example, right? From a public health perspective, we say masking is a great tool, and it's very important to reduce transmission of the virus, which, you know, science says is true. But if you put this into context, in a meat packing facility, if you have a mask on, you have your safety goggles on, you're in a cold environment, let's say you're working on the fabrication side, your goggles are going to get foggy, and there's really no way around it, and you can't see. So is it better to risk potential COVID transmission or cut yourself because you can't see what you're doing, or cut somebody else because you can't see what you're doing? And that was just one of the many examples that workers gave us about those contested measures. And then finally, they talked about the limited health services, again, thinking about the occupational health office in the facility, and how a lot of the COVID protocols were actually outsourced to third parties. So they weren't even handling COVID in the facility. And you actually had to call and try to work it out in different ways. The third theme is that COVID impacted workers beyond the workplace. And I think like many other working people here in the US, it affected their families in lots of different ways. And so they reported changes in their physical, their economic, their social, their emotional, and their psychological well-being. They described the fear of infecting their family members and the challenge of dealing with limiting your interactions with people, especially those who may have been in multi-generational households or the families who had children. And they talked about the challenge of being able to provide for dependent family members in other countries, and the financial stress that came from time off work and the constant struggle to be able to pay the bills. And a lot of workers talked about this idea of feeling stuck, like you're stuck in a job and a situation on the one hand that gives you income and some benefits, but on the other hand has a significant cost to your body, to your mind, and potentially to your family. They talked about, again, that limited social interaction with families and friends and communities. And let me give you an example here about a woman named Maria. She was a middle-aged woman who had been working in packaging, and she felt the need to provide for her family and the fear of infecting them, and that the pandemic was super stressful for them. And she said, well, if I stay home, who's going to help me with my bills? Nobody's going to help me. Carlos, another man in his 30s who worked again in fabrication, talked about the financial stress that he experienced and the pressure to provide for his parents, as well as his fear of infecting his parents. His parents were in their 80s. He says, my parents are old. They're 80 years old, you know, they're retired and everything, but I'm the one who pretty much works right now and pays all the bills and all that. How can I go where I live knowing that I have COVID? I don't want to give it to them, you know, I got so behind. Another person that we interviewed talked about the traumatic experience of basically carrying out a dying coworker. He said he died, and he died at work. He died going outside so he can drink his coffee and eat his banana. The company didn't offer to help him and help their family with anything. So now I'm finding oddball jobs and stuff just so that her and the children will have food, talking about the wife and the children will have food. I don't feel obligated to do that, but I'm the one who picked him up, and I didn't let him get on that gurney cart, and I carried him to the ambulance. So basically this gentleman who said this, he was a veteran, a military veteran. So he talked about how you never leave anybody behind. And here he had seen his coworker drop outside, and it took him back to being in a combat situation. He picked him up and he carried him out on his shoulder to that ambulance. I mean, imagine the trauma. But again, he had that sense of responsibility that I think many of our military veterans feel, of being able to feeling like you need to take care of the family after something like that happens. We asked people about pandemic acute stress, and here you can see that most of the people that we talked to had endorsed about 3 of these stressful symptoms. So having difficulty sleeping, feeling like time was slowing down, feeling like you're kind of in a daze, avoiding thoughts and feelings about COVID, avoiding reading or watching information about COVID, or having distressing dreams, or when something reminds you of COVID, it stresses you out. And so on average, workers described at least having 3 of these different symptoms. Theme 4 was that workers perceive benefits and shortcomings of the union. So we talked with union members and non-union members, and some talked to how the union had been helpful in resolving interpersonal conflict, especially between workers and supervisors, and that they're sort of like an arbitrator of disputes. But they also had some shortcomings. Like, for example, they had limited visibility and a very limited role during the COVID-19 pandemic, which they felt limited the union's effectiveness. They didn't have adequate staffing to be able to really deal with everything that was going on to help workers. And there wasn't a lot that they did with the day-to-day struggles to help workers. And so typically what we found is that their perceptions of the union was basically based on a very limited number of specific anecdotes that or incidents or stories of coworkers that workers were sharing with us. And theme 5 is that workers believe that infection prevention and control involves listening, learning, and humanizing production. Like, we've got to do a better job with this, that we should be talking to workers about what should be done in these facilities. Of course, there are some overarching things that we can do, but thinking about how do we really make things effective and how do we get people to do the things that we want them to do, we've got to talk to them. Right? For example, there was a gentleman named Carlos, and by the way, all the names are changed here for their protection. But he talked about how he wanted to get tested because he didn't feel well, and he said, to the facility, you just got to listen to workers if they're telling you something. If you're a supervisor or management, just listen. They're telling you we don't feel good. Just listen, please. And they talked about other general ideas to improve health and safety, like humanizing production. So taking steps to rebalance the prioritization of people and production. And finally, like I said, this research really helps us to corroborate the other results that we found through the exposure assessments, including the interventions focused on the common spaces and thinking about the situations that shaped some of these circumstances, like the limited time for breaks and meals and shift changes. It also demonstrated that the engineering component is something that really reflects food safety and not a worker safety or a human health perspective. And finally, based off these interactions with our workers, it really underlines the importance of considering the structural issues that many of these workers face in their daily lives and how that also shapes their vulnerability, their health, and their safety. So in summary for the exposure assessment, this had a really tremendous, the COVID-19 pandemic had a really tremendous effect on workers and their families. They had, things were difficult at work and also after work. And so the companies have implemented lots of different strategies, but sometimes there's policies and practices that limit the effectiveness of the things that they have done. And we need to really engage workers and try to understand what are their ideas, their recommendations for how to improve conditions in the plants and really reduce the fear that is associated with speaking up. Our team has now taken a kind of a three-pronged approach to thinking about how do we deal with COVID. We need to do things and in the work environment. We need to do things in the community environment. We need to have a treatment type of system that supports both of those efforts. So what I'd like to end with today is to let you know that there's power in research, right? It's not just about expanding and refining our scientific knowledge and trying to improve, the protection or intervention strategies that we may be, trying to disseminate, but it's also an opportunity for us to document those lived realities of people and uplift workers' voices, their concerns, their perceptions, and generate new perspectives, right? Thinking about the mask, all of us in public health probably wouldn't have thought of that, right? But if we talked to workers and they told us about that. And it's also an opportunity for us to use this data in building a case for enforcement, for evaluation, for the creation of policy, and to promote occupational justice. So now we have a new project that we are currently undertaking called Meatpacking COVID-19 and Infection Prevention and Control, Community Defined Solutions. You can see there's two purposes that are listed on the slide. It is taking place in 6 communities across our state right now. We're in Hastings, Crete, Schuyler, Fremont, Omaha, and Dakota City. We're conducting more surveys, more worker interviews, more stakeholder interviews, and a document and media analysis to look at how the rules and the promotion of rules in different communities varies and how that may have impacted COVID-19 outcomes. And what I'd like to do is ask you to be part of the solution with us. Are you a meatpacking worker? Do you know meatpacking workers? Because if so, we're looking for people to participate in a survey or in interviews related to their decisions about COVID testing, and about COVID vaccination. So the trick is that the people need to work in one of those communities. So if you work or you know people who work at an Omaha meatpacking facility or any of those other facilities that are listed on the slide, we'd love to have them participate. We have currently about 460 workers who've participated in this study thus far, but we're shooting for more. So they can text the number that is listed on the slide and then put interested in English or text interesado in Spanish, and we will have a research team member reach out to them. So Barbara, I'm sorry, I forgot your name, who's helping us with the webinar. Isaac. I was going to say Isaac, but I wasn't sure. Isaac, if you could post the flyer in the chat for everybody. You'll have a flyer that also has the text number and more information about the study. Please feel free to share that with anybody that you know. We'd love to have them participate. As I mentioned, we do have a $20 gift card for people who complete the survey and a $50 gift card for people to do an interview. Here, this is the work, as I mentioned, of a lot of people. I just get the privilege of being able to share it with folks. So this is our research team that has been working together for the past 2 years. And I would be happy to answer any questions. And I do want to thank, of course, the funding that has been made available to us. Thank you so much for your time and for your attention.
Thank you so much, Dr. Ramos. This is so thorough and so important that it's happening right here in our community. I think, first of all, I'd like to say a big thank you to the Nebraska Medical Center and UNMC, because we saw the involvement even from the very beginning of the pandemic, right? And it was such a, it was just so impressive to see that right here in our community, everybody was, in the thick of things. So thank you for your work. We have one question that you've touched on, but I wanted to present it in case there's more that you wanted to add to this about the union responsibility. What do you see as the union responsibility and benefit to plant workers? Is it mainly protection of employment, or do they also work to ensure safety and quality of working conditions? You did mention also at one point that they asked you for some feedback about some of the measures.
Yeah.
So,
yeah, they sure did. Yeah, I think workers understand the role of the union to be primarily around contracts and figuring out problems with wages. But they also did see that there's a great opportunity here with the pandemic that the union could have stepped up and taken a bigger role. Now, maybe that's because they aren't really clear, like an average worker may not know all the things that are happening behind the scenes at the national level that the union has done. And they have been very active on a national level, but I think facility by facility is really driven by their own experiences with the union, which is very limited. Oftentimes people hear about the union only when they come to new worker orientation. You have to sign, are you going to be union or are you not? And that's the extent of it. So there could be a lot more, I think, that could happen facility by facility around educating workers and trying to bring people together and moving beyond just the wage and contract issues.
thank you.
Mm-hmm.
Another question. Females tend to do more surveys, so it makes sense that more females than males did your survey. However, what did you see as the breakdown at the plant in terms of male-female employment? Can you give us a comparison?
Yeah, for sure. On the fabrication side, it seemed to be about 50-50. On the kill side, it was a little bit more male dominated. Those jobs tend to be a little bit higher pay because the work is a little bit more physically difficult. So, on the fab side, on the fabrication side, you have the lines running and you're doing, smaller cuts of meat versus on the kill side, you might be taking out guts and you might be cutting a whole carcass in half and that sort of thing. And so there were more men on that side.
Thank you.
Mm-hmm.
Has the percentage of male to female changed due to the pandemic?
Oh, that's a really good question. I don't have an answer for you, but my gut reaction to that is perhaps more women left the workforce or left those jobs during the pandemic than men did. for childcare reasons and for other family care reasons, and weighing the economic benefit, or, of, am I going to work here, get sick, and then what happens to my kids? Maybe I'll just stay home with my kids. That's my gut feeling, but I don't have any data to back that up.
A related question, just overall, how has everything impacted the workforce in the meatpacking industry? I think we go out and we see almost any business we go to seems to have struggled keeping their staff, right?
Yeah.
Have people left their jobs because of the consequences of COVID?
Yeah, absolutely. Absolutely. One of the facilities we visited, they're in a really remote area, and they were actually having to bus people into the facility from about an hour away because they didn't have adequate people to staff it in the small town where they were located. So they would run about 16, 17 buses a day back and forth from the large city into this smaller town just to be able to have people to work. But yeah, they have a lot of trouble with maintaining workforce and the high turnover rate. I mean, the industry has a relatively high turnover rate anyway, but COVID just made it even worse. Mm-hmm.
Okay. From your perspective, because we know that you've already shared that the plants are not going to share everything with you, so you're not quite sure if you're seeing reality, but do you believe the industry has improved, or are they going back to some of their old practices?
No. Oh, they're turning back. So as I mentioned, some of the facilities were giving bonuses and hazard pay and had lots of protective measures in place. But I think with, kind of the public perception that COVID is over, there's a lot of return to normal. So even when we were doing some of the on-site assessments during the fall, there were places that were removing their mask policies. We actually talked, it was an interesting conversation we had with one safety manager, and she mentioned how she wasn't going to remove her mask policy because COVID's going to come back and variants are going to come back, which they did. We remember the fall, we had lots of surge during the fall, and she didn't want to have to re-educate her people on why they need to put on a mask and try to reinforce, all these policies. So she kept the policy the same. But even just yesterday, I was reading an article about how about 70% of businesses across the US are returning to their pre-COVID types of policies.
What was the role of OSHA during this time?
That's a tricky question. You would think that OSHA is set up to protect workers, and they are, but they had a relatively limited role during the pandemic. OSHA came out with guidance for meatpacking facilities in late April. So many of the facilities already had experienced large outbreaks by that time. A lot of the large outbreaks came in late March and early April, and so those had already passed. OSHA struggled with having enough inspectors to be able to go out and handle some of these cases. And COVID has been kind of a contested issue in terms of where the liability lies. Does it lie in the workplace, or does it lie somewhere else? And how do you know that a case was contracted at the workplace? And so there was a lot of legal battles about how and if and when and what constitutes counting COVID as an occupational illness. So it's been relatively limited. There's been a few companies that have gotten fines from OSHA for their COVID policies, but they've been very minimal.
And another question, because of the lack of transparency, was the state able to track COVID clusters to the plants?
Yes and no. So the data that I showed you from Fern with the map, the heat map, those were cases that were tied directly to meatpacking facilities. Now, in our state, the way that data was collected was through contract tracing. And so if people actually went through the process, then they would be classified as a meatpacking worker. However, if they didn't, then there was no way to tie that case back to meatpacking. The cases in our state that are tied to meatpacking are only the worker, not the family members or friends or other people who may have gotten the virus from that worker as a result of, potentially the workplace. So the numbers are in our state, it's roughly around 7,400 or so cases that are tied to the meatpacking industry.
Thank you. Your articulation of all of this is just so stellar. I really appreciate everything that you're providing. Because we're training people for the future here, I would like you to please share with us, did you know you would be in this kind of a role as you were preparing your career? And what are your recommendations for someone who has an interest in public health or research or the outreach component?
Absolutely not. I never expected myself to be working in this field. I grew up here in Nebraska, and I never expected to be associated with agriculture. I grew up here in the Omaha metro area, and now I do research with farm workers and meat packers. So it wasn't something that I had expected. I came into public health, I guess, by way of chance. I worked in a community organization with a public health program, which moved me on to Creighton University, which ultimately led me to UNMC and the College of Public Health there, first as a program coordinator, then a program manager, an instructor, and then I went back to school to do a PhD. What I learned with PhDs is that they push you to try to be so very laser focused and narrow in what you study. And I never felt like I could do that because I see the world as so connected, like what I've shared with you today. Things that are happening in work are happening at home, and there's a lot of connections for why things happen the way that they do, and also are kind of situated within our context, within our communities, and within the policy structures at the macro level as well, that influence everything. And so I saw everything as very interconnected. And so I had a little bit of a challenge trying to find a PhD program that would work for me. But I did. At Clemson University, I found a program in International Family and Community Studies, which is an interdisciplinary program that brought together public health, human rights law, community development, anthropology, sociology, and psychology, among others, right? And so it taught us to look for those connections between those disciplines. And I think that's really been an asset for me in my career. So what I would recommend for people who are trying to go into public health, I would consider UNMC. We've got a great public health graduate program for folks who want to do this work, who want to be involved in community and really be kind of that link between a healthcare institution or a healthcare facility or a public health department or a clinic or so forth with the community. Public health is a great career, and you can do that through getting a master's degree in public health, which we have at UNMC. We also do offer certificates in public health, which requires a completion of five core courses in public health. I think that I think now with the pandemic, people know what public health is. But before the pandemic, people are like, public health, what's that? And for me, it's been a great home because public health is really everything that we do every day, right? From the seatbelt laws, to the water that we drink, to the ground where our houses are built, to the ground where our food is grown. It's really an integration of all of these different types of sciences and different disciplines. And so for me, having this interdisciplinary focus, I think public health is really a great home. Plus, I really love to be with people and help people. And so public health has been really good for me in that respect as well. But I definitely encourage you to check out UNMC.
Thank you so much. We've got one final question, and I'm going to kind of wrap it around something that I was thinking when you first started. So the pandemic hits around here at Metro. It's like early March. Then all of a sudden, March 2020, everything was really like, oh my gosh, what's going to happen, and et cetera, et cetera. We were really busy trying to figure out what our future was, but we were highly protected, right? We're going to thank our institution. They they had those who could work from home, etc. That wasn't the case for people in your position. You had to really just jump out there and probably not able to isolate yourself. So we've got a question. Was it hard to jump into this project while parenting your kids? And she comments that you're very brave, Athena. Your leadership skills show in all the work that you've done.
Oh my gosh, thank you. What a great compliment. Was it hard? Yes and no. Meatpacking, as I mentioned, we had been doing this kind of work even before the pandemic. But for me, getting access to facilities was an incredible opportunity because I just never had that kind of access before. And it was just, I think, a blessing too, to be able to share the information with community members who needed it. So there were many nights that, I'd be up all night, 6, 7 in the morning, and my family's like, "What are you doing? Go to bed." But I'm like, "But I could save people," there's just such a sense of responsibility with the information and also with the stories that people shared. Like, they shared it because they wanted us to do something with it. And so I felt like we had to do something with it. Otherwise, we're doing wrong by the people who shared those stories with us. Did I worry about infecting my family? Yeah, sure, of course. I did, but I also did most of my work from home. And I have the privilege of working with infection prevention and control specialists. Like, this is what they do. Some of the best in the world are at UNMC. And so they were also guiding us on what were the measures that needed to be taken. And so there was, yes, a risk, but I felt relatively protected and a huge sense of responsibility in doing this work.
We're so thankful to have you and all of your colleagues who have headed things, and we wish you the very best as you move on to further powerful impact on communities across the world, truly. Do you have any final comments for us, Athena? You've shared so much.
No, I just want to thank you all for your time. Thank you for listening. I think this is important. As I mentioned, I bet all of you, and just looking at some of the names around the table today, I know you have connections with these workers. So please feel free to share that flyer, encourage your friends, family, and acquaintances to participate in the study. We're definitely trying to do these types of studies to improve the working and living conditions for the folks in our communities. So please help us help them.
Thank you. Thank you so much. Isaac, can you put up our slide? While he's doing that, one final big thank you to Dr. Ramos for giving us her time. We know she's extremely busy, and it's just been such an honor to have this message here today. So we have an online evaluation. It's also in the chat and it will be emailed out to you. Really would appreciate your feedback. And thanks to everybody, and have a great afternoon. And thanks again to Dr. Ramos. We appreciate you.